Hello, everyone, and happy TNL. Guess who I have with me today? Somebody who is from my state, not only that, from really close to my city. We're both from pretty much the same city in Brazil. And we met for the first time in Vienna, I think.
Yeah. It's a
We
small world, right, Renata?
It's
But
crazy. We had
you're much younger than me, right? So it's a
wow.
different generation.
But how many countries did we have in Vienna this year?
I believe it was more than 20, right?
I think it was about
It's
25,
27. Yeah, something like that.
something like that.
It was amazing.
We were, I think, the only ones from Brazil, but not only that, the same city. And if you guys know Brazil, Brazil is a pretty big country. So it's pretty incredible that we were both there. Hello. I'm going to be sharing this really soon with everybody. But let me introduce the speaker for you guys today. We have Dr. Daniel Ramos, which is not really how you say his name, is the Dr. Daniel Ramos, presenting our speaker, an orthodontic specialist with a master's degree in orthodontics since 2002. He combines academic work with his private clinic in Brazil, focusing on innovation and aligner therapy. As guest faculty at iHDS in Houston and UCAM in Spain, and a key opinion leader for DSD, he lectures internationally on digital orthodontics. From 2018 to 2021, he practiced at Well Clinic, the Coachman family's renowned private practice and birthplace of digital smile design. Since 2019, he has served as Orthodontics Clinical Director at the DSD Planning Center in Madrid, where he has planned over 5,000 digital orthodontic and aligner cases worldwide. Wow, what a bio. The topic today is Beyond Straight Teeth, Facially and Airway Driven Orthodontics. I am very honored to have you on the Airway Circle stage. The stage is yours. Welcome.
Thank you, Renata. Thank you so much. It's a great honor for me. I'm a huge fan of Airway Cycle and everything you are doing here to put all these specialists, colleagues together here. It's an amazing platform, and I'm still learning a lot, right? I learn a lot in Vienna as an orthodontist. If you allow me, I'm going to start sharing, okay? And
Yes, please.
let's play
And guys, he's
here.
the only one that understands when I drink this. Everybody's like, what is that? You know?
For some minutes, I missed mine here. I had one here too. Well, it's what I want to share today. It's a little bit of my journey as an orthodontist. It is a little bit of what we are doing at Digital Smile Design here in Madrid, working in partnership with many clinics all over the world. And also, well, to show what I believe orthodontics should be nowadays, right? Focus in area, focus in not compromising area mostly, because if we go back in the past, we can see that many times orthodontics actually uh, didn't concern about area aspects. And well, this is something that Renata already anticipated to you guys. Before we start, this is how I started there in Vienna, in the Vienna Area Congress. When I talk about orthodontics and I'm trying to explain to someone what we need to do for my patients, I like this analogy. Imagine that we are building your dream house. Okay. If you ask me, Daniel, can you build my dream house? I can explain to you my ideas. I can explain that I'm going to build with 3 bedrooms and a garden and a barbecue place because Renata and I, we are coming from the south and barbecue is very important. So the pool, and then I can explain everything, but probably what you are imagining and what I am imagining are completely different. Okay. And this is how I was practicing orthodontics in the past. If a patient came to my clinic, I was trying to explain what we need to do, but the patient didn't have a clue. Okay. With the digital and all technology we have, nowadays I can show something to my patient. Okay. I can show something that maybe it's exactly what he wants, maybe it's better, maybe it's not, but we have a starting point here and the patient can participate in the process. In this case, you may look to this house and say, okay, this is amazing. This is what I want. If I can, I will build this, or maybe not exactly what you want, and then we can change. Okay, this is the beauty of the digital planning in orthodontics. But we have digital here, right? We have the digital, and if I go back in the past and see this bite, I would say, okay, this is what I want as orthodontist, right? This is what I want. This is a class one, a corrected midline, overjet and overbite are acceptable. Okay, so this is what we should do, okay? But we need to look more than just teeth. And the same case, if I bring just one aspect, if I just bring the CBCT and I try to move teeth to the position that I want, we can see that this house here will collapse, right? It wouldn't be stable, wouldn't be a long-lasting home for my family, okay? Because this is a question I have been doing and a statement that it was kind of a quote in the Vienna Area Congress, right, Renata? Once you see it, you can't unsee it anymore. So the minute I start seeing CBCTs as an orthodontist, first, I start not sleeping very well at night because I was very worried about my protocols. I need to change because what I'm doing here, I may be moving out of the bone, I may be collapsing the arch. I need to do something different. But the fact that I can see, it helped me to do better, of course. Okay. And this is the question I have been doing to myself for a while. Uh, if I am a class one driven orthodontist, if class one is all that matters to me as an orthodontist. And for many, many years, I need to say it was, okay? And this question in the past, the same way, Renata, you have this platform, I was doing a podcast. This is a question I did for many, many colleagues. And when I started investigating what I used to do in the past, I found this paper here. This is a paper, I'm not going too deep in details, okay? It's a very orthodontic language here, but to treat class 2 patients where we have this angle here, the SNB reduced and the SNA normal, meaning that the problem is in the point B on the mandible that is more retrognatic. I cannot consider treating this patient using a mask, using retraction of the upper arch, okay? Because the maxilla is not that bad and the problem is in the lower. So I was looking to who is this author here, and this is just a joke because this is the paper I published, me published when I started working as orthodontist. So this is what I was doing to my patients. And I promise you, I was doing what I consider it was the best for them. It was what I learned. It was what I was seeing, right? But again, nowadays that I can see more, I can see it was a huge mistake to take class 2 patients and try to retract the upper arch, okay? So this same question I did to the amazing Claudia Pinter and the amazing Stanley Liu in my podcast, and we started brainstorming about this, and the conclusion was that there are so many things that we can improve for our patients more than just teeth. And we need to see much more than just teeth to be able to do this improvement. And class 1 should be just a piece of this puzzle, okay? So when we're talking here about orthodontics, how to build this perfect house, how to build this perfect smile. The first thing I needed to do was to move from a classic orthodontist concerned about intra-arch alignment, inter-arch relationship to a modern orthodontist. Bringing the face, bringing airway, bringing everything that can complement, because orthodontics alone cannot solve all the situations, and bringing the digital, because the digital was a game changer. With aligners, I'm not saying here that is better, that is worse, but it's the only way I can integrate our plannings, our interdisciplinary plannings, our analysis together in one platform, so we can guide the movements we need based on the face, airway, and in the function. Okay, so more than just teeth, we have the face, because in the end, the orthodontic treatment should look good, right? And then we can complement ortho restorations if needed, etc. upon anything. We have the occlusion, of course, if you can finish in class 1 better. But this is the last thing here in this slide. We should concern about airway. If to achieve a class 1, the question is, are we compromising airway with the approach we plan to do, only with orthodontics? If the answer is yes, it's better to not do it. We need to understand if where we need to move, we have bone. We need to understand if we'll finish the case with the TMJs in a comfortable position to the patient. So we have many, many aspects that we should be considering. In the digital workflow, when we talk about digital, we need to bring to the table a lot of simulations, a lot of time planning and diagnosing, which is basically the number 1 and number 2 here of this line, okay, these steps. What we do here in our planning center to help the dentists work with us is to create these steps to facilitate the evolution in the case. So we always start like an architect with an idea, creating a design. In this design, we're going to, in 3D position, the teeth where it should be the ideal position to the face, respecting transversal width of the maxilla, respecting the AP relationship. And then this is just an idea at this moment. At this moment, we can make all the mistakes in the computer, right? And here we can later, by understanding what it is, this final position, in a reverse engineering process, also understand everything we need to do to achieve this. And if orthodontics takes part, we can simulate all movements, including understand if it's possible to treat only with orthodontics, and use the digital to present this to the patient and motivate the patient to accept the ideal, to accept the best treatment for the patient, okay? So here, the secret here of the digital is to put together all this, because in the past, I had a great software to plan aligners, but then if I want to plan restoration, I need to go to another software. If I want to make analysis of the error, I need to another software. So here, with this platform that DSD is offering, is basically one digital line, everything done at the same place, okay? And after that, to move after patient accept, to move to number 4, and also 5, which is evaluate if the outcome was good. This is what the orthodontist can do, but now understanding that the final position was defined, it was validated in all these aspects that I am commenting, okay? So this is a huge difference for the orthodontics that I used to do in the past, because in the past I was looking, how can I move the molar to class 1? How can I put the cuspids in class 1? Now I'm understanding where they should be according to area and face. And then I can understand if it's possible to get a class 1 only with ortho, if maybe I need to do orthognatics, maybe I need to do a mandibular advancement, maybe I need to consider opening the vertical adding restoration. So there are a lot of things that I can do more than just orthodontics to get there, to not compromise area. So this first step of our journey, it's actually give a step back. Let's forget about movements at one moment, and let's evaluate patient's face. Let's bring the facial analysis so we can have a better idea if it is something that is going to look good. Let's get back again. Remember the architect, right? The architect, he can start with a drawing to give you an idea. And this can motivate me as a client, and then, okay, let's do a better project. Let's understand now what needs to be done to achieve this idea. So the face can be this initial thought that motivates the patient, and that can guide us in terms of what we need to do later, okay? So we always understand and we start by the upper arch, okay? And here in the software, the ability we have nowadays to overlap STL files of our intraoral scanning with photographs and CBCTs, we can have everything integrated. And this is not the part that I want to invest more time in this lecture, but basically we are validating if the idea of this design in terms of midline, posterior expansion, temp correction, it's going to be good. It's going to look good in patient's face. And after doing this, we can also present this to the patient. This is something that leads us to the second step. After we validate with the face, and here is the topic that, of course, I want to invest more time, is how to bring Airway to this discussion. Okay, can actually orthodontists improve Airway? So before we talk about ortho, we need to understand some parameters. Okay, in the Vienna Airway Congress, I learned from Dr. Stefan Decker that where there is smoke, there is fire, right? So we need to become very good detecting the signs that can be a risk factor for airway problem. And to not see these, it's a missing opportunity for prevention. This is I also learned with Christian Lerner, my good friend, that we cannot miss anymore these smoke signs because again, once you see it, you cannot unsee it. And I'm glad that I'm talking here for a very uh, wide group here in terms of specialties, in terms of uh, focus, but in the end, we are uh, moving to the same direction, right? We are all concerned about our patients about airway, and to help your colleague dentist or to help uh, your team or the doctors who are referring patients to you to better see these signs. I think this is the first step. Even if they are not a super specialist, they need to become very good detecting this. And this is where the DSD jumps in, and having this group of specialists there in our planning center to be doing this analysis and plannings, we are helping them to at least see the smoke, and then if they are not the ones who are going to perform the treatment, to refer for those or who can do this. Okay, so there is what we call acquired pandemics, and these smoke signs, right? Sometimes we kind of neglect, okay? And uh, if you ever have the chance, and know Renato, you know him very well, to listen or to talk to Dr. David Alfin, you're going to be fascinated about how he deal with this, how can he explain about what we call the quiet pandemics, okay? Because probably you know much better than me, but the impact of a mouth breathing, the impact of not breathing well to our health. Okay, we can be reviewing these slides for the whole day, the full day, and it's not going to be enough. But it's considered normal nowadays to need the need for to extract a third molar. As an orthodontist, it's part of the process. The first thing, okay, let's extract the third molars, and that let's start the ortho. For a long time, it was considered normal to extract premolars. I'm seeing that more and more we are doing less this, and for years inside the DSD Planning Center that we are not recommending this anymore, because actually extracting a premolar, it's like your house that you are building, and you build this house for your family, and it's you, your wife, or your husband, and you have two kids, right? And then you're expecting the third one. So what you need to do, are you going to ask one of your kids to go out so the third one can come in? Of course not. You need to build a bigger house, right? To extract your premolar is like asking one of your kids to go out, right? It's kind of crazy if you do this analogy, but this is what we were doing as an orthodontist. So we are solving the problem by treating the consequence and not the problem, right? So these red flags. I was super impressed talking to Stephen Decker, Christian, and everyone there, Claudia, you, Renata, everyone there in the Vienna Area Congress, because I was trying to build something easy to the dentists who work with me, for them to understand these risk factors when there are signs of compensation and symptoms. And this community that we are creating, right? And it's getting bigger. Uh, we are using what part of what I learned in the Vienna Area Congress, part of what I'm discussing with David Alfie and Todd Shire in Houston, part what I learned with Rick Robley and Mariana Evans. So we are trying to put together a very simple questionnaire that I can share with you later, but this is something that, yeah, I know you have a more complete one that came from Stephen Decker, and probably you use different ones, but this is the simple thing that we can need to evaluate to raise the red flags to check for these signs that I'm not going to go deep here because you know this very well, right? In terms of creating a score about these signs, these smoke signs, these red flags, okay, that can be a indicator of every problem, okay? Renata, we reduced to 10 red flags because I'm talking to dentists that they are starting with this concept and we just need something to, okay, there is something going on here, right? And they can justify to the patient to do this planning, this interdisciplinary planning with area analysis that we are offering and that we are recommending. Because in the United States, I know that it's easy for any dentist to ask for a CBCT or even to do in their own clinic, but in Europe, it's not the same. Some countries, they have some challenges. So since we are working with clinics all over the world, this is the first step that we are recommending for them to, okay, this patient may have a problem. So they can use this score to as a next step to justify ordering other exams and indicating, for example, to do an orthoplanning with area analysis that we are going to do, okay? So when we receive the case, imagine that you did this questionnaire, your patient has a score 7, so probably has an issue, area issue, and then you are going to do a CBCT full head, and you are going to submit all the files, the photos, STLs, and this is where, after the facial analysis, we're going to start in 3D understanding where the problem is. Is it a transversal problem? Is it an AP problem? Both? How is the posterior area volume? There is any constriction? So we're going to bring all these measurements, all these reference that we have, and like we're creating this 3D box of decisions, right? This 3D box that if we have an ideal transversal width, if we have an ideal position of the point A of the maxilla, if you have an ideal volume in the posterior, so we are creating this 3D position of the upper arch that we can in the computer do everything, right? For the good and for the bad, but let's do for the good. And then if we can do everything, by doing this analysis and by moving to where we need and comparing to where we are, it's very easy for us to understand what needs to be done, okay? So first requirement, and this is basics, it's to take a CBCT a full head, so it can copy the biggest fall possible, so we can copy the posterior area, ideally the TMJs, and all the points that we need to mark. For this CBCT, what we are requesting is to have the patient in maximum intercuspation, with the tongue relaxing the palate, and ideally in the horizontal position, okay? I know that it's not easy, no, not everyone has a CBCT that can do this, okay? But if we can choose an ideal way to do, this is what we are recommending, and I'm completely open to discuss this if you have a bit different idea. So here, this box, since we have sagittal reference for area, transversal reference for area, and vertical reference for area, let's try to put this inside the mouth of this patient to understand if this box is smaller or bigger, or if we need to move it, okay? So the first thing that we are using as a reference is this PVA line, this podium vertical, and measuring in a linear distance in millimeters from this line, okay, to the point A. And all the reference we have in the literature say that ideally the point A of the maxilla, which is the most internal part here, should be advanced in 98 millimeters distance to this line. So if we do this and the maxilla is here backwards, we already know that probably there is a AP component here that may be causing the posterior obstruction. Okay, so we have margin to discuss with the patient moving forward, okay, the maxilla. We also use the true vertical line. The true vertical line is very used for orthodontics to understand the ideal position of the upper incisor, okay? And it's a kind of a challenge measurement because depending on the deficiency on the maxilla, sometimes we need to compensate, and the position here in the angle between the nose and the lip probably is not the best position to put this vertical line, but it's just a reference to complement the other, and ideally the incisor should be from 7 to 10 millimeters from this vertical line, okay? In terms of volume, this is a discussion that I have been doing since the first Vienna Area Congress. And after two courses in Houston, that it is a course I organized together with Mariana Evans, David Alfie, and Todd Shire. Um our conclusion is that the ideal volume of the posterior area should be always bigger than 30 cc's. Okay. And here, I feel that this is important to reinforce. We need to calibrate where we are measuring, okay? Because I already saw in many congresses comparing before and after how it's better the space, but in the beginning they measure in this area and then this area. So you should always calibrate. And what we are doing, we are using as a upper reference the posterior nasal spine and in the lower epiglottis. If you always use these two positions, you can have a better understanding on the impact of the treatment in the posterior area volume to avoid any discrepancy. Okay. And also the minimal section, the area that we have the biggest constriction. Patients that they have less than 300 millimeters square, they potentially may have obstruction in some moments of his day or during the night. So these colors here, the bigger the space, the bluer it is. So Alfie always like to say about the blue ocean, right? He's always looking for the blue ocean there. And if we have more than 300 millimeters square, it's going to be blue. It's going to be a lot of space and it's going to facilitate the patient to breathe. Okay. In the CBCT here, the software, this is the Nemotech software. Okay. There are many other software that are calculating this, but here we are checking the posterior nasal spine, creating this area there in blue. And then we can ask the software to detect volume and make out the calculation. Okay. Okay. I know. CBCT, you may say, okay, that's not the best exam to evaluate this. I agree. It's getting better. It's just a reference. And combining with all the red flags, combining with these, and then combining with all sleep studies that we need to do, this is something that can be evaluated with the exams we have in our hands and serve for us to indicate something the next steps. Okay. Thanks to Christian Lamher for this image. Okay. This is just for you to compare what it should look like a normal airway, green to blue, and where it is a narrow airway when the problem is, when we start seeing in red, okay? This patient here probably is not breathing well. We discussed the anterior posterior, okay? We already have a good reference for our patients. We using these measurements, we have what is the ideal volume posteriorly and where is the ideal position of the point A, the upper incisors. Let's go to the transversal. And here, I have two mentors that I really respect, being unfair with many others, but Mariana Evans, has a lot of studies about it, okay? And also this image here, it's interesting because if we have a constriction in the maxilla, as you can see here, you can see how the roots are almost trying to move out of the bone, right? And there's no space for this amount of teeth. So the quiet pandemics that Alfie is always mentioning is related to the shrinking of our jaws, right? And if the maxilla is already constricted, imagine solve a crown by extracting teeth. Imagine doing a lot of IPRs. So we are not solving the problem, okay? So we need to understand in the transversal way if it is just a dental constriction. I don't know, for some reason, the teeth are retroclined, but we have a good bone distance. If it's a mix of both, or if it is a skeletal deficiency, okay? The other mentor for me is Eric Tuller from UPenn. He's a Brazilian doctor. He's based in UPenn, and he has some amazing studies creating correlationships between these transversal weed and area issues. Okay, and one of these papers says that when we have a reduction in the interpremolar and the intermolar distance, measured here in the bone, normally in this junction between the bone and the cervical area of the tooth, This distance, if it is reduced, can be a sign that the patient may have obstruction. Okay, so as a reference, he used as a limit point. Okay, 27 millimeters in the first premolar and 34 millimeters in the first molars, meaning that when you have these or less, the problem is there. Okay, so of course we need to look for more, and the ideal, the common sense is that we should achieve like 38 millimeters. But again, we may face a patient that 38 is not enough, and we may face a patient that 38 is a lot. Okay, so we need to understand also what one of the most important components of this environment, the tongue, what the tongue is saying. And this is a topic that I won't get in because I have the best person to talk about it, Renata. So we also evaluate the architecture of the palate, okay, the height of the palate. So when we have a palate that is super narrow and like in this fjord V shape, this is one of the worst combination. No space at all for the tongue. Okay, no space at all, and then here the tongue is there working 24/7, right? And this is why most or many of the orthodontic treatments, they are not stable after all, because simply we are not paying attention to the tongue. Okay, we are not seeing to the tongue what it is telling us. Okay, and most of the time, this is not the orthodonts who are going to understand, because I am doing my baby steps to learn more about it. Okay, and usually I am I am suggesting the dents work with us to talk with Renata, to start creating the team for them to work together to be treating these patients. Okay, so in our workflow, what we do to guide our decisions, to understand if what we are doing makes sense to Airway, is this box of decisions here that we evaluate the posterior area volume, the anterior posterior reference to the ideal position of the maxilla, the upper incisor, the height of the palate, and also the ideal transversal width of the maxilla. Okay, doing this and respecting this, the third step will be the function, of course, because if I respect these measurements and I am positioning digitally in a way that I'm going to be with the proper transversal width, and I'm going to position AP, my arch or array, maybe deciding not to retract in a class 2, just maintain what it is. By understanding where the upper ideal position is, now what it rests for me is to see the lower relationship. Where is the lower, right? If the lower is retrognatic and the maxilla, after I do all this analysis, I kind of lock in this position, I have few ways of treating this, or I will consider orthodontic surgery to move forward, or it's better to accept, if the patient doesn't accept orthognatics, I need to accept that it's better to leave it in a class 2 than to try to find a class 1. Okay, then to achieve the class 1 by changing the upper. Okay, so it simplifies a lot my diagnostics in terms of what I need to do in terms of class 1, 2, or 3. Okay, so the function is something that comes after all these analysis, after the face and after Airway. So now is the moment to deprogram the patient if necessary, to understand where it is the centric position, and then to plan what I need to do to better intercuspate with the upper arch. Okay. Here basically are the three pillars for us to have a ortho treatment respecting Airway. We need to always start by the face, then evaluate Airway and check if we're going to compromise, and ideally we need to improve if possible, and bring in the function in the end. If we have all these and we are also in peace with the tongue, I'm pretty sure that this case is going to be stable. I'm pretty sure that aesthetics are going to come in this right, and things are going to be working much better for this patient. in a simplified way, upper first, respecting face and area, coming later with the lower with the function, TMJ, and occlusion. Okay. In this journey, right, when we are doing this process, we usually stop a little bit, okay, here to present something to the patient. After we do the facial analysis and bring a design, this is a good moment to bring the patient on board, say, look, this is our idea. You like this? Because this is the moment to motivate the patient. The patient, of course, some of them, they're going to look for you because they have a lot of problems and they want a solution because of sleep apnea and, well, TMJ pain, clicking, etc. But most of the patients that are out there, they are in a zone that they probably have some airway problem and they don't know yet. Okay, and we can see this. And the best way that we believe is to bring them to motivate them. Okay, and by doing this, we understand that as soon as the patient is motivated, he is seeing what we are. In the past, we have something in our mind that was hard to explain with words, but now we can actually present this to the patient and they can be excited about it. The chances for this patient to accept the ideal plan is much bigger, okay, much bigger. And then we can avoid the camouflage treatments that the patients that are going to your clinic with a huge crown and they just want to change a restoration here in this incisor and you are, oh my God, there's much more I can do for, but he's completely closed. And you try to explain, you try to bring, and sometimes this patient goes home and ends up not doing the ideal. So this process really, really increase the case acceptance to the ideal. Okay, and this is the core business of DSD from the beginning. Okay, this is where DSD started, doing this sequence of planning simulations and then doing a mock-up so patient can see in their own face. Here is not the final outcome. Here is just this design here that it's in the computer that we can adapt in patient's mouth so the patient can visualize and have a taste of what is coming. This is my patient from Brazil, the same process. This patient came just to do veneers and we could convince her without saying anything, just showing a design and showing a mock-up that ortho can do something for her, and we save some teeth from preps and restorations. Okay, and how technology it is, these designs we're creating, respecting the bone area, we can later bring inside a software like this from SmileCloud and transform a photo in a video, and the video is showing the before and the after. And this after is not AI generated thing, is based on the design we created respecting area. So a patient to see this, she's much open now to accept what we are explaining to her. Okay. Let's see some cases, right, Renata? Because I think this is the moment that the person who is presenting all these ideas can be sometimes a dentist, can be sometimes an orthodontist, can be sometimes, but in the end, it's a team effort, right? And the digital can really help us to understand everything we need to do and who are the persons who should be on board. I don't know if you have any questions for now, if you want to give a quick stop.
Mind is just blown, and the fact that you can make a video out of an image based on the treatment plan, it is.
Yeah,
I mean,
because
nobody will say no to that. It's incredible.
Is the AI we have, if you go to Gemini from Google and put a photo, he can create a smile design, okay? And the patient may be in love, but we don't know if it is possible and we don't know if it's going to do good to this patient. So this is dangerous, actually, right? It's like promising something and don't deliver later. The video that I show is actually based on a planning, based on something that not only one dentist, but a group of specialists together evaluated, okay, from my side as orthodontists, we can do this, but I cannot go more. Here is Alfie, he needs to do MMA. And then later it's with you, Renata, because the tongue is there not in ideal position. And then we create the ideal position together. And then we generate a video to motivate the patient. So we can really sleep well at night knowing that, okay, this is what I promised. We have the blueprint here. We have the formula. Now it's just a matter of executing this sequence, right? Um, in terms of orthodontics, we have this umbrella that we call DSD orthodontics with DSD, okay? And we have a planning center to help dentists to do these plannings, to later to plan the aligner software. We create guides to place tabs. We are creating guides, and we are partnership with labs to do the custom MRP. We are doing guides to do SFOT, right? Rick Rowley is one of the best ones using RP, SFOT, Todd Shire too, orthognatics, and our plannings are considering. So it can facilitate the dance to discuss with Alfie or another surgeon, of course. I mention Alfie because he's my surgeon. Or even for the cases that, okay, this patient is not accepting anything, we can at least present a mandibular advancement device, which is just something to compensate and not treat. Okay. So a case like this, right, that this patient is there, first appointment with some complaints. Okay. These kind of planning, and I want to bring this case fast because this patient didn't start with any area complaint, but just to show the process. Uh, this is a case that many times an orthodontist would extract this premolar. Okay. And then I need to deal with these spaces. Probably let's retract the upper. Okay. And then I may reduce space for the tongue and maybe not stable. Okay. So by planning in his case, doing this process, first, we can again make all the mistakes here in the computer, right? So I am placing the design, and let's see how it look like if I distalize and move the premolar to its position. Okay, it's not easy, but it's possible. Okay, and the patient deserves to know everything we can do, and here it's a better way to present to him. Okay, we can also understand if we can improve the proportion because he has small teeth, and we can check in his face. And here, seeing the difference, we can see that he has small teeth, not only in the incisal edge, but also in the gingival margins. So we are going very deep to understand everything we need to do. So let's open space for this implant. So we need to extract the premolar. So here we are, digging very deep to understand the treatment we need to do for this patient. How far ortho can go, where restorations jumps in. Let's open the vertical. Again, everything in the computer is being planned. Uh, the implants we plan also the same moment, because this way I know, okay, this case I cannot place the implant before ortho. I need to first move distal and then place the implant. I am simulating the implant, considering the final design, the final ideal position. Okay. And then, okay, let's show this to the patient. Let's do the mock-up. So here the patient is test driving the idea of this design, considering everything we're going to do. I never saw in all the course we do a patient that didn't like it, because this is a moment that they really get excited to see this. It's not perfect. It's not something you give a mirror to the patient. They need to see in a video, in a photo, because it's something that we move forward. It's very bulky, but gives a great idea of our architect drawing, okay, about the project. Okay, this is something that most clinics who are working with us, they mentioned that increase the case acceptance significantly. Okay, but now we have a plan. Now we have a sequence that it will help to perform. We will use the TPS to guide in this case was Invisalign with the clean check. We will do a TAD guide to place the TAD to help moving and intruding here and moving the smaller. We have a guide to place the implant. We have a guide to do the crown lengthening to adjust the gingival margins. And we have a guide to help prepping the minimum amount possible teeth to add the restorations where needed. Okay. So here the case, it's being planned with this skeletal anchorage to move, to intrude a little bit the second quadrant. So we position guided to understand exactly where we need to place. You notice that everything we're doing in the sequence, this is a very dental moment of the lecture, is guided by the same design, okay? Because the TAD is positioned where we should add the anchored system to achieve the final position, okay? And we consider the final position of the root, so to avoid any collision. Okay. In the lower arch, well, this is the quality control. Another thing that is an advantage of the digital. This design in white that we took in consideration, airway, face, etc. We always go back to the computer, and once the ortho is progressing, we can always overlap these meshes and then see if it's good enough or if we need to move more. Okay. In this case, this is the outcome of the ortho. So it's very, very close and inside its design. Here, the patient after ortho with the orthodontist who works with Jesus Criança Seville. So we concluded the orthodontic treatment. Now we're going to move to place the implants, to do the restoration. So we adapt the same design over the position we achieve. We do a more technical mock-up to see how it's going to look like. Now, not moving forward, not being bulky in his mouth. We simulate if we're going to do just restorations with composites, prepless. So here it is the new mock-up. The guide to place the implant in the position we planned originally. Okay, so this is the implant. The quality control showing that the position inserted was exactly the position we planned. Here, a guide to adjust gingival margins to be very well leveled. Okay, and here, very important, we can see the ideal final position of the gingival margin and see if we have enough space to the bone. That is important. This, for those who are periodontists, know what I'm saying about. The guide can help removing not only soft tissue, but also adjusting where the bone level should be. Let me move forward here because this is not related to airway. So the guide is here. The patient is doing the procedure, removing this minimal excess, very fast surgery. Renata, you just did it, right? You know what I'm talking about, right? So this guide is guiding the dentist to remove minimally this to be exactly as the design was shown to the patient and what the patient approved, okay? Sometimes the patient decides not to do, but if he wants to do, we can go exactly there, okay? And here, finishing, measuring, adjusting, quality control. So let's go to the final because he has small teeth. And then we use the same design to guide the restorations in a technique that was created here at the DSD, the pressed composite. So we can really be minimally invasive. And then we can use this tray to press the composite. It's a midterm solution, so the patient can use this for many years. And if he likes, then he can change to veneers that need some prep, and then it's more invasive. But now we know that it's working, that it's functional, that it's aesthetics, and the patient likes it. Okay, so here we're getting to the end of this treatment, before and after. And here the patient is still a little bit numb, but a huge, huge difference. And very similar to what it was planned from the beginning, okay? And again, it's not fair to say that this is a DSD work because this is a team effort. A lot of people were involved, and we need to, I need to, how can I say this in English? And move my hat, as we say in Portuguese, to these guys because they did a great job.
Give credit where credit is due.
Give credit, yeah, thank you. And just to link now to what probably is more our topic, right? Case that we have MARPI, we are going, the decision of the device is very related to the orthodontist that is doing. I really like the custom-made MARPI, right? And I really like the technique that Claudia and Rick Robb, they are using to combine aligners and expansion at the same time. But again, the important here is to split the suture and increase the transversal width, okay? So how can we help dentists to visualize this, and how can we help dentists to explain this to the patient? By, well, showing what is going to look like if I am going to move digitally teeth to this ideal final position. So here, look, these lines that are guiding my design, how are more expanded if compared to the posterior teeth, okay? And this is, again, just an idea, okay? By looking here, I cannot know if it's possible or not. I can suspect. With my experience, I'd say, okay, this expansion demolar we probably won't achieve. It's going to flare teeth out, and it's probably not going to be good. But imagine that I have 20 years of an orthodontist as an orthodontist, so it's much better to see it. So now bringing the CBCT, if I'm going to put the CBCT, I'm going to see there that these roots, if I move them to the ideal position according to the transversal E that we want to respect, look how out of the bone these roots are going to be. Okay, so this is first not possible. Second, can generate a lot of problems to the patient. So by doing this, we can simulate, okay, instead of moving backwards to the bone, and then I'm not solving the problem, let's leave the roots there and let's understand how much I need to expand the bone to cover these roots. Okay, so here we are simulating even before we do anything. So by understanding this, I also know exactly what kind of ortho I need to do after for case that I want to expand first and then do the ortho. Okay, so now I can already start the ortho in the lower arch. Okay, and here is basically the kind of simulation we can do to help to explain to the patient why we are suggesting to do an expansion, a dome technique with MARP. Okay, this case, it was performed by Dr. Jacqueline Lowe, and here's the outcome of the expansion with a custom-made MARPI manufactured and designed by Partners Dental Studio in the United States. And the outcome, simply amazing. Okay, so we did a quality control to compare what we planned with what we achieved. Okay, and now we could move from 26 intermolar to 36, so an amazing outcome. And now we're planning to finish the case. We are more and more integrating the DOM XD to control the diastema to our plannings. It needs to control a little bit the tipping of the roots, but for adult patients, they don't like the idea of having this big diastema, and it is a technique that is really, really growing because of that. Okay. Well, Renata, this is what I had to bring here today to you guys. What we have been doing, how we are planning this case, how we are using this digital planning to. I don't like to use the word convince because it's kind of strong. I like to say to make patients see with their own eyes the advantage of treating to go into the ideal, right? And the one thing that I would like to, if from your colleagues that are participating in this webinar, if they already know DSD from the past, and if they have any relationship, DSD is all about doing restorations. I hope that with these plans that I presented and our workflow, they change their minds because actually we are all about trying to avoid restorations every time we can. We are all about trying to avoid extractions, trying to avoid the camouflage treatment by presenting this kind of simulations, okay? And let me know if there is any questions. And again, I am super happy to be here with you guys, and I have all the time if you want.
Yay! Thank you, thank you, thank you. What a wonderful presentation. You can now stop sharing your screen so they can see us really, really big. And I do have some questions. I think that one of the biggest challenges of any dental practice, that being orthodontist or anything else, is case acceptance. Do you know what is the average of case acceptance in an orthodontic practice with and without digital smile design?
I know because actually when I was working at Well Clinic in Brazil, where we started implementing the DSD there, right? And the clinic it had a history of ortho without having this process. And then when I started there, we used DSD for all cases. So what's the problem with an interdisciplinary clinic without DSD or without using the digital? I don't want to give the idea that it's just with DSD, but without using this interdisciplinary digital planning. Most of the time, the patients they are going to do other things than ortho, right? And then he's there, and the person who is evaluating is not an orthodontist. The patient doesn't want to do ortho. So puts together both. In our numbers, it was 10 to 20% of these cases were diagnosed properly, and a minimum amount was doing ortho. So the business of orthodontics when I arrived in the clinic was really, really low, the number of cases of ortho. Ortho was considered like a necessary evil, a problem. Okay, this case needs to be ortho. Okay. And when we started doing this, what changed? Uh, Even though the person who was presenting the planning wasn't an orthodontist, by doing these simulations before present the patient, I was not in São Paulo, I was in Porto Alegre, but I received these presentations, I was reviewing, and I was providing my diagnostics and my insights. So the person who presented the patient now has my opinion for all cases. So now from 10 to 20%, we start detecting the need to do something related to orthodontics for all cases. And because we are showing to the patient simulation, most of the time, we didn't need to convince it. It was just showing the overlapping between you are here and ideally should be there. And, oh, I see. Our numbers, they grow from 10% of case acceptance for 90% of case acceptance was incredible. For an interdisciplinary clinic. Of course, if you are talking US, an orthodontic clinic, they already have a huge volume, okay? But then we need to start talking about another case acceptance, a case acceptance to the ideal and not to the simple ortho to the fast ortho. That is still, it can help in this way too.
What is the future of traditional orthodontics? Because we have all of these incredible orthodontists that are graduating with just the basic traditional ortho that you don't see children until they're 12 years old. You don't start treatment until they have all of their permanent teeth. And then I feel like there's a new wave of orthodontists who are looking a little bit deeper, seeing kids a little bit earlier. What do you think the future is for orthodontics?
Well, I really think that orthodontists, they should start being more dentists again, okay? Uh, I came from a reality that in Brazil it's a very competitive, and I know that the United States is very different. But I also see because of the digital, because of the possibility of a dentist to use a planning center to plan digitally to have support, more and more they are doing these cases. I can see more GPs doing airway cases than orthodontists. It's a tough number. So for me, the future passes through a mind shift, passes through orthodontists going more to the Airway Congress in Vienna, right? Discussing more the interdisciplinary, be open to be adding not only what they can do with aligners. The same way we have the implantodontists that are just space driven. They place the implant because the space is there. So they should talk to the orthodontists. We need to talk more. And the future passes through use these technologies as a platform to be discussing in an interdisciplinary way, right? I feel that this is the way.
I love that 100%. So I
Yeah.
would like right now to invite everyone listening to come join us at the Vienna Area Congress next year. They don't have the dates on the website yet. However, I can go ahead and let you guys know it's going to be October 16th, 17th, 18th, that weekend. It's only 2 days. I'm not sure if it's Friday and Saturday or Saturday and Sunday. However, go
I
ahead.
already blocked October just to not
Yes.
take the risk to not be there because it's amazing. I always come back refreshed and thinking different. So everyone should be there.
It's such a wonderful group and it's multidisciplinary. And you have just these visionaries from all over the world come on there. Really, really good lectures. And I think that the most fun thing that I'm always scared every single time is the morning run. So, Dr.
Maybe next year I participate this time.
You have to come next week. So Dr. Florian Six does a Vienna tour at like 6 a.m. It's cold, but it's not bad. It's about a 5K, and we don't run the whole time. So we run a little bit and we stop, and he shows us all of these incredible touristic spots in Vienna, but it's incredible because there's nobody out at that time. And it is so fun for us to do something that, I'm not used to running, especially in the cold, especially outside, running at all.
Yeah.
And
If
always
I
prepared.
was, yeah,
I
sorry,
never
Hannah,
think I'm
please.
gonna be able to make it, and then it's fine. So, and we always take also mouth tape, and it's just such a fun thing to do. And then right after that, we go to the conference and we open up with the breathe on session with me teaching you guys some fun breathing exercises. So
Yeah, I brought my tools here to exercise.
very good. So I would
I
love for you guys
really
to meet us.
I envy those who are starting now and have the chance to go to this congress very early in their career, right? Uh, it's all about uh, learning with the mistakes, and we are out there sharing our mistakes, right? No one there is just showing the big cases, beautiful, successful cases. The ambience, it's a very humble. People are very open to be discussing. So I would say, if someone here asks me, Daniel, where should I start? I say in two places, one in this group, because it's amazing, and the other to go being there in the Vienna Area Congress. And those who want something more advanced and related to ortho, well, this year we are sold out already, but the course in Houston, the Beyond Peri Ortho Limits, it's a great place. And probably next year, no, the other one, I'm planning to take you there, Renata. This year, it's going to be Lupi and Susie Quintana team there
Yeah.
talking. Alfie is going to be there, Mariana Evans, Claudia Pinter, Stanley Dew,
Yay.
Todd Shire. So imagine 3 days being the third day, hands-on, fresh cadavers. If you
Wow.
want to learn how to play some RP, we have a lecture in the last day just talk about complications, right? So they are open their hearts and say everything that happened, how can uh, avoid. It's an amazing advanced course. And another one that I'm planning to go next year, it's the Rick Robley course, right? That he in Arkansas,
He's amazing.
Claudia's Pinter course in Vienna, right? So you have a lot of opportunities, and I feel that this community is growing. Probably next year, the auditorium we had a congress there is going to be small,
Well, I believe.
and this is the future. The future is if you have a friend that is orthodontist, you need to bring him to the congress. You need to bring on board because you're doing him a favor, and he will be better prepared for what is coming. The patients, more and more, they understand. Look, the AI in 5 minutes, AI can generate a book about orthodontics and
Yes.
neuro very fast. So patients, they have access, right? So they're starting linking things, and we need
Mhm.
to be prepared.
Question. If anyone listening to this would like to start working with digital smile design, what do they have to do?
Well, we have several levels, right, of, let's say, subscription to be working with our planning center. If they just want to use our TPS, meaning, oh, I want Daniel and his team to help me with my liner cases, basically, they just need to register in our web and already submit cases, okay? Differently than any other TPS, and I know this because I know all TPS out there. Uh, for those who don't know, TPS is treatment planning service, right? Uh, we are going to be there supporting with insights, clinical insights, and I'll help from A to Z. It's not just to plan a clean check or to plan a clear correct, etc. It's to be there as a virtual orthodontist, right? And to do this is basically register in our web, and our team is going to contact. Then, if you want to do these advanced comprehensive plannings, we have what we call the provider subscription, which includes a lot of content in terms of education, access to all of our courses online, and we will pay monthly fee, and then you receive these in credits to, because if you want to plan a case, we charge this planning per case, and then you change for prod. So you have this also this other level. It's a more complete one, for access to our products. And the highest level is the DSD clinic. David Alf is a DSD clinic because he already understood the process he's using, and then he has a full support, and he has our team, our specialists in a WhatsApp group, and it's some even more comprehensive support. You can share my content, Renata, my mail, my Instagram. They can find me through you and or even WhatsApp. If someone here wants to test, let me know when I put in contact, and I can guide. My team can guide better in terms of the
Perfect.
best
Do you
first
mind
step.
sharing your email address and I'll write it down also?
Do you want me sharing now or share it later in the
No, just go
the?
ahead and tell us what it is.
It's D Ramos altogether
Okay.
at digitalsmiledesign.com.
All right. I am putting that in the chat box. So it's DRAMOS at
Yeah,
digitalsmiledesign.com. Awesome. Thank you so much. I'll have anyone from Airway Circle reach out to you if they are interested. Thank you so much for this incredible lecture. Oh my goodness. I know I have so
thank
many
you.
more questions, but we're out of time. Maybe you need to come back.
No, you can share me later if you want, and I can answer uh, with time. It's going to be my
Yeah.
pleasure. They can find me on Instagram. It's Daniel Ramos Orto with TH, and well, I'm very accessible. So
Awesome.
let me know. And Renata, again, thank you for the invitation. I was truly honored. I need to congrats you. I want to congratulate you because I know what you're doing is changing, is shaping the future too. Okay, and I'm glad that I'm part somehow. And now with this webinar, I'm going to be there. And if you need me again, let me know. Okay.
Thank you so much. Everybody, have
Bye
a
bye.
wonderful night. We'll see you next week. Thank you so much.